This is okay. I found a good position. Oh,
Okay, I think we have a good number of people who have joined. Good evening, everyone. It's a real pleasure having you all today in this very interesting topic. I believe that we will be talking about an interesting ongoing topic that conjoins many specialties and organs together. Um, Recently, I mean, and although it has been ongoing for a while, but we have gained more knowledge about it. Again, connecting all the organs, the heart, the kidney, the liver, the pancreas, the metabolism in general, cardio-renal, metabolic syndrome or connection. And it's interesting because there are now a number of drugs that help in all of this together. Today, we will be touching on one of the classes. It's an old and new, but the non-steroidal MRAs specifically, and their game-changing aspects in the cardio kidney metabolic syndrome. And I'm delighted to have with me today Professor Javier Morales, who's an associate professor at Hofstra Northwell Northwell University in New York. He's an internist and interested in internal medicine, diabetes, and obesity, and will take us through this topic. After which we will be having some question and answers. Please submit your questions as you like, and we'll take them for a discussion. Pretty sure it's going to be very fruitful and full of knowledge. So please, Professor Morales.
thank you so much for the great introduction. I know that this is an interesting platform at this point in time. I think we've all become accustomed to using Zoom. So I'm just going to start my little broadcast here. For those of you that are signing on there, I don't know if you've heard, but in the New York area, there has been a tremendous, tremendous snowstorm. And as a consequence of this snowstorm, I am snowed in and transmitting from Orlando, Florida, which is the land of Mickey Mouse. Anyhow, without further ado, I know everybody's time is very valuable, and I'm grateful to be delivering this presentation to you. This is a little bit of my background. I think that the slides will be shared with you for your own edification and also for you to review some of the information that I will be showing with you today. So this is basically the topics to be covered, and you can see that there's quite a few, and there is a lot of data there, a lot of slides, but I'm sure that a lot of this information that I'll present is just going to be superficial for you because I'm sure you already know about this. So let's talk about the importance of the holistic nature of coordinated care for our patients with diabetes. But first, let's start with the case. So this is Fuad, 58 years old. He's got CKD and type 2 diabetes, and he's on a maximal tolerated ACE inhibitor angiotensin receptor blocker. So if we look at his demographics here, he's had diabetes now for about 8 years. He's got CKD that was detected about 6 years after his diagnosis of diabetes. And you can see that his A1C is 7.7, blood pressure 138 over 80. Definitely not where we want it to be. We want that blood pressure to be 120 over 80. And he is obese with a BMI of 32. Now, let's take a look at his kidney stuff because his GFR is 65 and his UACR is 150. So when we're looking at somebody like Fuad, we could see that his kidney function is actually impaired. His GFR is 65, but take a look at that UACR. It's 150. And what was so compelling is that it has gone up following his last visit. So again, I mentioned about the blood pressure. Blood pressure really should be 120/80. That should be the target. But we can't ignore his hemoglobin A1C and certainly his blood pressure. So right now we need to be thinking about, well, what are we going to do for somebody like Fuad to get him under better control? Well, let's take a look at this KDIGO heat map. So this was actually a heat map that was put together by the Kidney Disease Improving Global Outcomes Consortium, which is basically a collection of nephrologists worldwide. And what they did was they plotted along the x-axis your urine albumin to creatinine ratio, and along the y-axis your UACR. And if we're looking at this, we could see that green is good and red is definitely bad. So this winds up being a very, very powerful tool. I use it in my office all the time because for the patients, it's very convincing about the trajectory of where they're actually going. So if we're looking at this, Fuad is actually sitting on that yellow box. We're going to come back to that yellow box in a little bit, in a couple of slides later. But we could see that he can go in either direction. He can continue on to orange and go on to red, which is going to be progressive. If we're looking towards the center of the portion of the slide, we could see how his UACR has changed and also how his GFR has also changed over time. So I think it's important to remember that KDIGO does emphasize coordinated care with our patients with chronic kidney disease and type 2 diabetes. And like Fuad says in the right upper hand side of the slide, it's not always about the glucose, although the glucose is important. But I think it's important to remember that promoting self-management, exercising a team-based integrated approach is going to be really important with appropriate lifestyle intervention and institution of appropriate pharmacologic therapies in order to get our patients a little bit better. Now, even though this is data from 2022, it really hasn't changed very much in 2026, and we're waiting for the next KDIGO guidelines to come out. So let's talk about the need for early diagnosis of CKD progression in patients with type 2 diabetes, because what we do know is that compared to having type 2 diabetes alone, if you have CKD, your risk of having myocardial infarction increases twofold. Heart failure increases by about fivefold, including hospitalizations for heart failure and cardiovascular death. Now, of course, this is going to be taxing not just on the patient, but also on the healthcare system and healthcare expenditures, because you can have increased emergency room visits and hospitalizations, and even a progression to hemodialysis by as much as 40%. So I think it's important to recognize that chronic kidney disease and implement therapies a little bit sooner rather than later. Now, we do have a lot of societies that help guide us along in terms of how to best explore our patients' needs and how to manage their diabetes. We have the American Diabetes Association, we have KDIGO, as I mentioned, we have the American Association of Clinical Endocrinology recommendations, and the European Society of Cardiology. And they all recommend the same thing, which is screening and identifying chronic kidney disease with appropriate intervention early on in order to circumvent any kind of issues from happening. Well, let's take a look at the timeline, because I think it's really important for us to remember the fact that we need to stay away from being GFR centric. And we've been using glomerular filtration rate for many, many years because we dose our medications that our patients are taking based on GFR. But the GFR is never really the story, the whole story. There's something that becomes abnormal before the GFR becomes abnormal, and that is the urine albumin to creatinine ratio. In fact, the UACR will rise most of the time, about 90% of the time, before there is the decline in GFR. So identifying that abnormal UACR and implementing the appropriate therapies can actually have a significant impact in terms of the future decline in that glomerular filtration rate. So let's talk about UACR and what kind of prognostic factors does it offer? So if we're looking towards the left-hand side of the slide, looking at composite cardiovascular outcomes, we could see there the linearity in these data looking over 48 months in those patients who have a UACR of 150 milligrams, or those who have 150 to 300 milligrams versus those greater than 300 milligrams. I apologize for the legend there, but for the most part, yeah, it just tells the whole story. And that's the fact that as the UACR becomes abnormal, your risk of having a cardiovascular event increases. So we do know that there's an interrelationship between the heart and the kidneys. And oftentimes, As mentioned before, if the kidneys are abnormal, the heart's going to be abnormal. So what about kidney outcomes? So if we're looking at that UACR, your progression towards end-stage kidney disease or death increases significantly based on that UACR. So as a consequence, we really shouldn't be ignoring GFR, but really need to be checking that UACR. So current guidelines do recommend checking eGFR and UACR testing at least once yearly for both, and implementing that little heat map that I had shown you before, helping to assess cardiovascular risk. Now, the latest iteration, which I didn't show you about the KDIGO heat map, actually will also grade cardiovascular mortality risk. If you have significant proteinuria, that being greater than 300 milligrams per gram, then the ADA does recommend the reduction of that UACR by at least 30%. So that's very, very important, and that's a number that you should always remember. Try to drop down that UACR level by at least 30% or so, okay? So let's take a look at UACR as an important and easy measure of kidney health, because I think it's really, really important to see here that the American Diabetes Association does recommend using either a quantitative analysis for UACR, or you could send off a spot urine. And the spot urine could be assessed quantitatively by the laboratory, but you can also do a urine dipstick. And the urine dipstick test actually will tell you right there and there in a semi-quantitative fashion what the UACR would actually be. Now, in order to make that diagnosis of chronic kidney disease based on UACR, you should have about 2 out of 3 positive tests with UACR measured within a 3 to 6 month period of time. So the UACR collection, either quantitatively by sending it to the lab or semi-quantitatively with the urine dipstick, is actually quite accurate and quite helpful. So as a consequence, 24-hour urine collection really needs not to be exercised. So let's take a look at type 2 diabetes, chronic kidney disease, and how management has evolved over the past 40 years. So at the very beginning, when we're looking at the 1980s and so forth, we always talked about treating blood pressure as the first therapy to intervene in terms of chronic kidney disease. And then in the 1980s and the mid-80s, we started looking at glycemic control and glycemic variability as a cause of potential oxidative stress. Then new drug classes became available. That is angiotensin-converting enzyme inhibitors and angiotensin receptor blockers. And then it's been a really long stretch before new agents became available. And agents that were used for the management of diabetes, such as the SGLT2 inhibitor, did prove to be useful in terms of managing chronic kidney disease, independent of whether you have diabetes or not. And as a consequence, SGLT2 inhibitors really are recommended, again, regardless of whether you have an SGLT2, if you have diabetes or not. Now, finerenone did also prove itself in the Fidelio study, and as a consequence, gained the indication to delay the progression of chronic kidney disease related to diabetes. And then more recently in 2024, we had the first dedicated renal outcome study using a GLP-1 receptor agonist, specifically semaglutide, which showed a significant reduction in the progression of chronic kidney disease related to diabetes. And that trial was so compelling that, like the SGLT2 inhibitor studies, those trials were actually halted early because of the proven benefit that was demonstrated. So let's take a look at the history, because one of the first studies looking at chronic kidney disease was with the angiotensin receptor blocker, and that was the RENAL study looking at losartan. And relative to placebo, we could see that there was a significant reduction in UACR progression. And when we're looking at the pagliflozin, which is the SGLT2 inhibitor, again, we saw a significant reduction on the order of 36% in terms of the progression, delaying the progression of chronic kidney disease related to diabetes. So even though we see benefits with RAS inhibition and with SGLT2 inhibitors, as you could see there in the gray shaded areas in these slides, residual risk continues to exist, and we really should be focusing on chopping down that residual risk. So how do we chop down that residual risk? And we should really be focusing on a holistic, pillared approach towards the management of type 2 diabetes and CKD. So what's in our armamentarium? Well, we have RAS inhibition, SGLT2s, GLP-1s, and finerenone. So as we know, RAS inhibition does create efferent arteriolar relaxation, and as a consequence, it can actually preserve intraglomerular pressures or reduce it and preserve those nephrons a little bit more. The SGLT2 inhibitors work largely by creating afferent arteriolar constriction driven by tubuloglomerular feedback on the basis of the solute that makes its way to the proximal convoluted tubule, because the drug basically blocks the absorption of glucose at that proximal convoluted tubule. So when it gets over to the macula densa, it leads to different regulatory chemical messenger release that leads to afferent arteriolar constriction. Now, we really don't know about the GLP-1 receptor agonists and why they exert significant benefit. We might be looking at things like intraglomerular pressure reduction, NFK receptors, and a bunch of other things, and maybe even weight that could be a driver. But nonetheless, they show significant control. And when we're looking at a medication like finerenone, finerenone does decrease intraglomerular inflammation, but not just within the level of the glomerulus, but also in the heart and also in blood vessels. So here we have the ADA EASD consensus report, and basically looking at a holistic patient-centered approach towards managing our patients. And we all know that the common comorbidities that our patients suffer with include retinopathy, nephropathy, and neuropathy, as well as associated cardiovascular disease. So if we're looking at an individualized approach, we really should be asking whether or not our patients do have atherosclerotic cardiovascular disease, if they have heart failure, or if they have diabetes with chronic kidney disease. And as a result, they do give guidance in terms of what to do. And the crux of all of this is going to be a patient-centered approach with shared decision-making, because that ultimately drives adherence to medical therapy and a greater likelihood of success. So let's take a look at some of the guideline recommendations for CKD screening in patients with type 2 diabetes, because this is the European Society of Cardiology recommendations. And if you have confirmed type 2 diabetes, now it's broken down into two sides of the graph. Towards the left is confirmed cardiovascular disease. Towards the right is confirmed chronic kidney disease. And in these red dots is basically the class recommendation based on the strength of data. And as we can see, for the most part, GLP-1s and SGLT2 inhibitors wind up being at the forefront of therapy on top of RAS inhibition. But if you have chronic kidney disease, they specifically call out using a medication like finerenone to further curtail the decline in kidney function related to type 2 diabetes. If we're looking at the American Diabetes Association, of course, they recommend using this patient-centered approach, which is looking at glycemic management, blood pressure management. And when it comes to blood pressure management, again, the target is 120/80. And the cornerstone of therapy there is going to be RAS inhibition. However, when we're looking at cardiovascular and kidney benefits, once again, they call out the SGLT2 inhibitors and the GLP-1 receptor agonists, but they also specifically call out non-steroidal mineralocorticoid receptor antagonists, such as finerenone, which you'll learn a little bit more about. So let's take a look at some of these guidelines. And when we're looking at management of chronic kidney disease related to diabetes, I think it's important to exercise a pillared approach. So there used to be 3 pillars for management of patients with type 2 diabetes, but in actuality, because of more recent data, that's actually expanded to 4 pillars. And this, again, includes RAS inhibition, SGLT2 inhibitors, GLP-1 receptor agonists, but the non-steroidal mineralocorticoid receptor antagonist is a very important part of that pillar. So we all know about, life's essential 8s. Everybody should be eating healthy. Physical activity should be performed. Smoking cessation should be performed. And they also give us a little bit of a guideline in terms of where we should be managing our patients with first-line therapies, second-line therapies, and the addition of finerenone when appropriate in patients with type 2 diabetes whose GFR is greater than 25 with a normal serum potassium if their UACR is abnormal, that being a value of greater than 30. And again, when we're looking at all of these recommendations that were, and all these guidelines that have been described, we all talk about how the NSMRA has made its way into the forefront. So let's talk a little bit about finerenone, some of the phase 3 clinical program, and even beyond. So first, let's talk a little physiology, because when we're looking at the RAS system, it all starts with angiotensinogen, and we could see the cascade of events that ultimately lead to the production of aldosterone, and this leads to mineralocorticoid receptor overactivation. Now, the mineralocorticoid receptor is actually a ligand that sits in the plasma and actually, basically in a cellular plasma, and as a consequence, moves its way into the nucleus and acts as a transcription factor. And this leads to overactivation and production of items that could lead to fibrosis. And this translates into hemodynamic factors that are not satisfactory for the heart or the kidney, and leading to damage in the kidney itself, leading to albuminuria. So this will translate into glomerular sclerosis with decreased renal blood flow and interstitial injury at the level of the kidney, but it also increases the risk of fibrosis, worsening heart failure events, and myocardial hypertrophy at the level of the heart. So I've mentioned finerenone a couple of times already, and it is a non-steroidal mineralocorticoid receptor antagonist, but how does it differ from a steroidal mineralocorticoid antagonist? Because we have two steroid-based ones. We have spironolactone and we have eplerenone. And when we're looking at these agents, they tend to be flat, and as a consequence, may or may not fully bind to that mineralocorticoid receptor. So the selectivity is really not that high. There's also some anti-androgenic effects. And what's very important here is the half-life. When we're looking at these steroidal-based MRAs, they tend to last a very, very long time. And they tend to be a little bit, well, favoring the kidney more so than the heart, although eplerenone was supposed to be kind of equal. However, when we're looking at a molecule like finerenone, it is not steroidally based. And as a consequence, it fits the mineralocorticoid receptor more completely. So there's a high selectivity for that mineralocorticoid receptor. As a consequence, it also has a shorter half-life, and it tends to be balanced between the kidney and the heart, which means that you have less of a likelihood for sexual side effects, as well as less of a likelihood of having hyperkalemia. So when using a medication like finerenone, we could see that this will lead to decreased inflammation, decreased fibrosis. It'll decrease albuminuria and improve hemodynamic factors, which will have a cardiometabolic and cardio-kidney protective mechanism of action. And I'm going to show you this in some of the slides that follow. But first, how do we know that a medication like finerenone reduces inflammation? So this was some data from the Figaro study, which was a dedicated kidney outcomes study, and there were inflammatory markers that were actually evaluated. These included fibronectin, osteopontin, COL1A1, interleukin-17, and both C and D. And we see that these inflammatory markers were indeed decreased. So the promise of finerenone reducing inflammation was demonstrated in this. So these downregulation of markers actually mediate heart and kidney benefits across the clinical trials. So I'm going to show you some data. This was a pre-specified meta-analysis of two pivotal trials that were conducted, the Fidelio and the Figaro. Let me explain a little bit about Fidelio, because Fidelio was a study where it was designed to demonstrate a decrease in kidney function, looking at progression to kidney failure or a decrease in GFR of greater than or equal to 40% or more. That was the primary outcome. But since we know that the kidney is inherently related to the heart, there was a secondary outcome, and that was its effect on major adverse cardiovascular event. And this was cardiovascular death, non-fatal MI, and non-fatal stroke. So that was Fidelity, looking at a kidney-centric approach towards managing our patients. That was the primary endpoint, with the secondary endpoint being the cardiovascular benefit. So when we're looking at, that was Fidelio, let's take a look at Figaro, because Figaro was the exact opposite. So Figaro actually looked at a primary cardiovascular outcomes, looking at a reduction in major adverse cardiovascular events defined as cardiovascular death, non-fatal MI, non-fatal stroke, and hospitalization for heart failure. And in addition, there was a secondary endpoint, which was the kidney endpoint, and that was the progression of chronic kidney disease with a decrease in glomerular filtration. Now, when we look at both of these studies combined, they were not small studies. They were very, very large studies. And as a consequence, we had all of this data that became available from both of these parallel trials. And as a consequence, we had this pre-specified meta-analysis looking at both the data from Fidelio and Figaro. So let's take a look at the population of patients that was involved in this trial. So here you see that KDIGO heat map once again, and delineated in the black line is the patient population in both of these groups. Now, to the right-hand side of the slide, we could see that the Fidelio group, in order to enter the study, your UACR needed to be 30 and 300 with a GFR of 25 to 60, or a UACR of greater than 300. And if we're looking at the Figaro study, which was the cardiovascular outcome study, here we're looking at UACR of 30 to 300 with a GFR of 25 to 90, or a UACR of greater than 300 or less than 5,000. So you could see that they were actually quite equal. And when we're looking at the patient population that was involved, 7,437 patients in Figaro, 5,734 in Fidelio. So when we pool all this data together, you can see that we had 13,171 patients. So it wasn't a small study. And what was important is that all of the endpoints were pre-specified in this trial. So when we're looking at this fidelity analysis, this pooled analysis, let's break it down, looking at the cardiovascular and the kidney outcomes. In the center of the slide, you'll see the cardiovascular benefits. In this pooled analysis, we saw a 14% reduction in the risk of cardiovascular morbidity and mortality, with an even more compelling reduction in first hospitalization for heart failure by about 22%. Now, if we're looking at the kidney, we could see that the risk of progression of chronic kidney disease was reduced by about 23%, and a 20% reduction in the progression to end-stage kidney disease. How about that? You could actually delay somebody from needing to go on dialysis by about 20% by adding finerenone to their regimen. Now, as I mentioned before, one of the most predictive factors in terms of outcomes is UACR. And we could see that the UACR reduction was about 32% in this pooled population. So here we're looking at that UACR, and we could see that relative to placebo, there was a rapid reduction of about 36%. Remember, American Diabetes Association says reduced by 30% if UACR is 300 or greater. So we had a 36% reduction by month number 4. But what was really important is, if you look at this timeline, is the fact that that UACR reduction was steady throughout the whole trial. So when we're looking at fidelity UACR, we had an 84% mediated treatment effect of finerenone on composite outcomes and a 37% cardiovascular outcomes. So this is actually quite important, because now we see that there's an interrelationship with a significant sustainable reduction in UACR, which led to significant improvement in kidney outcomes as well as cardiovascular outcomes. So what about that 30% number? So let's say you have somebody who has a UACR of, let's say, 600, arbitrarily speaking. And if you were to get a 30% reduction, then you could bring that UACR down to about 427. But what's really important is somebody like, perhaps like Fouad, where you can actually start and bring their UACR even lower and put them into the A2 range from the A3 range. So this is actually quite important, and it's a very valuable lesson for some of our patients with chronic kidney disease related to diabetes. So when thinking about finerenone and how to use finerenone, there really are basically 5 things that we need to remember. We can initiate it if your potassium is less than 5, but you can actually withhold treatment if the potassium is greater than 5.5. Initiate the treatment when your GFR is greater than 25. And what's really also very compelling here is that we reduced the risk of progression to chronic kidney disease relating dialysis by 1/5, and hospitalization for heart failure by 1/5. So the rule of 5s winds up being very important and very compelling. So we do know that it is a mineralocorticoid receptor antagonist, And one of the things that's important is that you're going to be using it in patients with type 2 diabetes. And as one would expect, this is not a glucose lowering therapy. So don't expect that hemoglobin A1C to improve. However, what we can see is that regardless of your baseline hemoglobin A1C, insulin use, A1C variability, we could still use finerenone, irrespective of whether or not you're on a GLP-1 or an SGLT2 inhibitor. Now, what about blood pressure? Because we do know that sometimes we can use MRAs, particularly in patients with resistant hypertension. Now, finerenone is not an antihypertensive drug. However, when we look at this fidelity pooled analysis, there was a change in mean systolic blood pressure by about maybe 3.2 millimeters of mercury. However, if we were to break down the blood pressure in this particular treatment paradigm or treatment group based on quartiles, based on where their blood pressure lies, if you're in the fourth quartile, you could see almost as much as 10.8% reduction in their systolic blood pressures, and so on and so forth. You see an improvement of about maybe 4.8% in the third quartile and 1.13% in the second quartile. And of course, tends to be more blood pressure neutral at lower quartiles. Now, what about adverse events relative to placebo? If we're looking at treatment-associated adverse events, any treatment adverse event was 86.1% in the finerenone group versus 86.4% in placebo. And acute kidney injury was 3.4% in the finerenone group versus 3.6% in the placebo group. Now, what about anti-androgenic effects? So when we're looking at things like breast hyperplasia or gynecomastia, you can see it's relatively neutral relative to placebo. Again, because of the short half-life of the medication. Hyperkalemia does exist and it can exist, and we did see a little bit higher hyperkalemia with finerenone relative to placebo. However, when we're looking at treatment termination adverse events, looking at hyperkalemia leading to discontinuation or leading to death, you can see that really there was no increase in mortality related to possible hyperkalemia, and discontinuation rates were reasonably low. The mean difference of that serum potassium of finerenone relative to placebo was about 0.19. So that was a mouthful. We talked a lot about the individual studies there and the pooled analysis, but let's break it down a little bit more when we're looking at these forest plots. So when we're looking at the kidney outcomes, here we could see that overall there was statistical significance. But if we're looking at baseline glomerular filtration, separated there into 25 to 45, 45 to 60, or greater than 60, again, you can see that all of those data points fall to the left of the line of unity. And if we're looking at the UACR, regardless of whether it's 30 to 300 or greater than 300, again, all of these data points all fall to the left of unity, favoring finerenone, and to a statistically significant degree overall. So what about the cardiovascular outcomes? So if we're looking at composite cardiovascular outcomes in stage 1 to stage 3, here we had statistical significance that was achieved in stage 4. Again, the data point was to the left of the line of unity. If we're looking at cardiovascular death, non-fatal MI, non-fatal stroke, we could see that all of these data points all fall to the left of unity based on stages of cardiovascular status. Again, looking at stage 1 to stage 3, non-fatal stroke, it wound up being neutral. This is not an antiplatelet therapy. So, of course, we're probably not going to see any stroke-related events. But take a look at hospitalization for heart failure, because when we're looking at stage 1 through stage 3, and even stage 4, again, we saw that there was benefit in favor of finerenone for reducing these hard outcomes. Now, we do know that our patients do use SGLT2 inhibitors and they use GLP-1 receptor agonists. So let's explore those patients that were on SGLT2 inhibitors compared to those who were not. If we're looking at the cardiovascular composite outcomes, made absolutely no difference if you were on an SGLT2 inhibitor or not. If we're looking at the kidney outcomes, again, there was no difference whether or not you were on an SGLT2 inhibitor or not. All those data points all fell to the left of the line of unity. And just as a reminder, we did see that there was on average a reduction in UACR by about 37% by month 4 in those patients that were treated with finerenone and continued to persist throughout the course of the study. What about the GLP-1 receptor agonists? So here we're seeing similar data in cardiovascular outcomes and kidney composite outcomes, regardless of whether you are on a GLP-1 or not. If we're looking at these cardiovascular outcomes, again, all of these data points all fall to the left of the line of unity. And if we're looking at kidney composite outcomes, again, all fell to the left of the line of unity, which really indicates that there is really no difference in effect, regardless of whether you're on a GLP-1 or not. So now we looked at the sub-analysis, and these kidney benefits really are irrespective of GLP-1 receptor agonist use, regardless of baseline, regardless of history of atherosclerotic cardiovascular disease. So finerenone does show suit. So what about combination therapies? If we're looking at combined disease-modifying treatments with SGLT2 inhibitors and non-steroidal mineralocorticoid receptor antagonists, here we're looking at event-free survival, as depicted there in that black line. So if you're on an SGLT2 inhibitor, we could see that, yeah, that black line continues to drip downward as you are getting a little bit older. But if you're on combination treatment with an SGLT2 inhibitor and a mineralocorticoid receptor antagonist, take a look at event-free survival. It actually increases. So this is actually quite compelling and encouraging to continue using a medication like finerenone in combination with an SGLT2 inhibitor, if possible, to minimize some of those event rates. Now, we do know that some of these medications are quite expensive, and there are cheaper alternatives. And these are the steroidal-based mineralocorticoid receptor antagonists. And this is new data that was actually presented back in 2024, and it's called the BARAC-D study. And here they looked at low-dose spironolactone and on top of standard of care for patients with type 2 diabetes. And this was a prospective randomized open blinded endpoint trial. We call it a probe trial. And here we looked at event rates in terms of cardiovascular outcomes. And what we could see here is relative to placebo, low-dose spironolactone did not reduce cardiovascular outcomes compared to usual care in patients with stage 3B CKD. Again, another feather in the cap of the non-steroidal mineralocorticoid receptor antagonist. So now that we learned a little bit about SGLT2 inhibitors and how well they play in combination with non-steroidal MRAs, what about the confidence trial? Because this was a study that actually looked at combination therapy of an SGLT2 inhibitor and finerenone. So here we looked at, in the confidence trial, urine albumin to creatinine ratio in 807 patients. Now, when we're looking at this particular trial, I mean, if we were to look at composite kidney outcomes, it would take a tremendously long time in order to complete. But one of the most easiest measurable events that we could see when using these trials or using these studies is measuring that urine albumin to creatinine ratio, which is exactly what they did in this particular study. They were looking at UACR reduction by day 180. We were looking at the post-treatment UACR after discontinuation of therapy and long-term UACR change. Now, renal safety was also explored, and that was looking at that GFR slope at day number 30 and the sustained GFR change in this very short trial. And here you have your data from the confidence study. So when we're looking towards the left-hand side of the slide, we're looking at the least squares mean ratio of the change from baseline in that UACR. And I mean, the curves pretty much tell the story. And that's the fact that empagliflozin, which was the SGLT2 inhibitor that was used, relative to finerenone, if you're using either one as monotherapy, there you have a nice change in the UACR that was almost superimposable. But if you use both of these in combination, you could see as much as a 52% reduction in that UACR, which is far greater than that 30% reduction that was recommended by the American Diabetes Association. And if we're looking at changes in potassium and adverse events related to potassium, you could see that there was slightly greater events in the finerenone. But when we're looking at event-free events, the combination of therapy actually led to even fewer hyperkalemic events, suggesting that there is a protective effect by using an SGLT2 in combination with a non-steroidal mineralocorticoid receptor antagonist like finerenone on protecting potassium. So when we're looking at some of these primary endpoints, we saw that there were 32% greater reduction compared to empagliflozin in terms of the UACR. And if we're looking compared to finerenone versus finerenone, 29% reduction when using these in combination. Now, the Fine Heart study was an interesting study because here we looked at fidelity as well as the fine arts population in general. And again, this is a pre-specified pooled analysis with a very large population of patients, about 14,000 patients. And when we're looking at composite kidney outcomes based on GFR of greater than 50 or greater than 57, there's no mystery there that we're seeing even greater reductions relative to placebo in this pre-specified pooled analysis. And when we're looking specifically in Fine Heart, looking at cardiovascular death or hospitalizations for heart failure, major adverse cardiovascular events, hospitalizations for heart failure, you could see that the finerenone group did better. Now, what's kind of interesting here is if you're looking at curve E, because at curve E, here we're looking at new onset atrial fibrillation. And again, this was kind of an interesting finding that there was fewer events for new onset atrial fibrillation if using finerenone in chronic kidney disease with type 2 diabetes. And this did satisfy statistical significance. So I mentioned Fine Arts. Now, this was a dedicated heart failure study. And I apologize for giving you so much information, but I think it's really important for you to understand the power that this drug has, especially when looking at cardio-kidney metabolic syndromes. So this study actually looked at symptomatic heart failure patients whose EF was greater than 40%. So these were patients with heart failure with preserved ejection fraction or heart failure with moderately reduced ejection fraction. And the doses of finerenone that were explored here was 10, 20, and even 40 milligrams of finerenone, specifically when targeting heart failure compared to matched placebo. This was not a small study. This was about 6,000 patients, and the key exclusion criteria were exactly with that rule of fives, and that was potassium greater than 5 or a GFR of less than 25, and if you were using MRAs about 30 days prior to randomization. Here you have your data. And when we're looking at the effect of finerenone on heart failure, hospitalizations, and cardiovascular death, we could see that there was a significant reduction on the order of about 16% here that satisfied statistical significance. This was actually an absolute rate reduction of about maybe 2.8 per 100 patient years. Now, what's also really interesting to note here is not so much that there was a significant benefit that was seen with finerenone, but if you track this Kaplan-Meier curve backwards, you could see that the separation of the curves starts rather early, indicating that this is quite an effective therapy for helping our patients that do suffer with a history of heart failure with preserved ejection fraction or heart failure with moderately reduced ejection fraction. So let's take a look at the secondary endpoint, because in this slide, I showed you cardiovascular death and total heart failure events. But if we're looking at heart failure events, here we saw an 18% reduction in overall heart failure events that were reported. Quality of life also improved significantly in patients that were on finerenone relative to placebo, with a significant improvement in New York Heart Association class, as well as kidney outcomes, as we saw in this particular slide. So let's take a look at non-steroidal versus steroidal MRAs in a spectrum of patients whose ejection fraction is greater than 40%, because we're all very familiar with the data with spironolactone as depicted there on the right-hand side of the slide. And we can see that there is a linearity based on ejection fraction in terms of effective management. However, when we look towards the left-hand side of the slide, here we're looking at cardiovascular death, heart failure events, first heart failure events, all-cause mortalities. We could see that those lines tend to be a little bit flatter relative to spironolactone, suggesting that the non-steroidal shorter acting agent with more specificity towards that mineralocorticoid receptor seems to offer a better profile relative to spironolactone. So again, we know that our patients with type 2 diabetes do have a history of chronic kidney disease, and we do know that there is an additive effect between outcomes and cardiovascular events, should something like that exist. But what about our patients with type 1 diabetes? So this was the FIND-1 study. It's the only study that was actually ever done in patients with type 1 diabetes to see whether or not a medication like finerenone would be useful for managing our patients with CKD related to type 1 diabetes. And what we see here in this data was that the UACR did go down by about 21% at month 3 post initiation of therapy, which was sustained all the way through the point of evaluation and the conclusion of the trial. And even after discontinuation of the medication, we saw that there was a persistent decline in UACR rates relative to placebo. So finerenone is not only useful and beneficial in patients with type 2 diabetes, but we're also seeing benefit in patients with type 1s. Now, I did mention the pillared approach about using the GLP-1s, RAS inhibition, SGLT2s, and NSMRAs. And this was actually an elegant meta-analysis that was performed looking at outcomes, major adverse cardiovascular events, hospitalization for heart failure, cardiovascular death. And when we're looking at this combination of therapies, you could see that as we have more of these agents that are added to the regimen, you could see that that data point starts to move even further away from the line of unity, again, illustrating the fact that a pillared-based approach seems to make the most sense in terms of improving hard outcomes for our patients. So what about kidney disease? Because that was basically the cardiovascular stuff. But what about kidney? And we see the same thing in kidney. Kidney progression actually decreased significantly when we're using all of these agents together relative to 1 or 2 agents or even 3 agents. And the same thing with all-cause mortality. All of those data points all shifted to the left of the line of unity. So the pillar approach certainly is validated, not just in this meta-analysis, but also in the data that I just previously showed you. Now, this is the new proposed treatment sequencing pathway based on the American College of Cardiology, and this was published by Steve Green in the fall of 2025. And here we could see in our patients who have heart failure with an ejection fraction of 40% and when to use an SGLT2 inhibitor and an NSMRA based on whether or not they have chronic kidney disease, obesity, or heart failure history, and where these agents fall into place. Nonetheless, what's really important is the center of the slide, and that is if you have a history of heart failure with an ejection fraction of greater than 40%, then you should be using an SGLT2 inhibitor in combination with a non-steroidal MRA. So how do we use a medication like finerenone? So for the most part, if your GFR is less than 60, you should start with 10 milligrams once daily. If it's greater than 60, you could start with 20 milligrams once daily. 4 weeks later, check the potassium. If your potassium is less than 4.8 on 10 milligrams per day of finerenone, then it should be increased to 20 milligrams. If it's between 4.8 and 5.5, keep them on that dose. But if their serum potassium is greater than 5.5%, then you could withhold treatment, explore their diet, because a lot of people eat certain foods that are potassium rich. In Saudi Arabia, these could be citrus fruits as well as dates. After withholding their medication and exploring their diet, then you could probably restart the medication about 2 to 4 weeks later and follow this very same treatment scheme. If you're using finerenone for managing patients with heart failure, then you could actually increase and use a 40 milligrams per day dose using this very same schemata. So what about real world evidence? So for the sake of time, I'm just going to let you know that there were 2 real world studies that were done, Fine Real and Fountain. And when we're looking at these data, for the most part, they were US database research trials that were done using electronic medical records retrospectively and looking at key outcomes. And these included hospitalizations for heart failure, potassium, UACR over time, And these were some of the baseline comorbidities that were explored. And you could see that there was a tremendous amount of hypertension in most of our patients that were explored in this particular study. Now, what's kind of interesting here is also looking at the stage of kidney disease identified. And there was a significant amount of patients that had stage 3 disease. And if you're looking at albumin urea categories, you could see that there was a lot of patients that were in A3 and A2 more so than A1. So when we're looking at finerenone in combination with other treatments, about half of patients were on RAS inhibition. I shook my head when I saw that data. It means that we're underutilizing RAS inhibition. SGLT2 inhibitor use, only 38%. GLP-1 receptor agonists, only a quarter of patients, and there was still a substantial amount of insulin that was utilized. Nonetheless, we could see that a lot of patients were prescribed 10 milligrams, and 85.8% of those patients prescribed finerenone at 10 milligrams remained at that dose, and about 14%, 20 milligrams. But after a year, only 70% of those patients remained on 10 milligrams, whereas 29.8% were escalated to about 20 milligrams. So we need to do a little bit more than just initiating finerenone in some of our patients who really need it, but you should also be titrating it to the maximal effective therapy. When we're looking at incidence rates of hyperkalemia, quite low. And in fact, very, very low rates of hospitalizations related to hyperkalemia in this outcome study. Now, here's the UACR change, because even in a real-world analysis, we saw 39% as well as 41.2% at month 12 in that UACR in these patients that were treated with finerenone. So just to conclude this presentation really quickly, and I really want to thank you for your attention, is the fact that patients with CKD have a greater risk of adverse outcomes from a cardiovascular standpoint. CKD most commonly does occur in patients with type 2 diabetes, and we really should be using or checking a UACR at least once yearly in our patients. And as a consequence, finerenone does have the recommendation not just to delay the progression of chronic kidney disease related to diabetes, but also to reduce cardiovascular events that may be associated with chronic kidney disease. And it is a quite easy to use medication, and sub-analyses from Fidelity did show that there was demonstrable reduction in cardiovascular risk, irrespective of the stage of chronic kidney disease, and there was significant improvement in mortality outcomes, irrespective of that baseline UACR. And in real-world evidence, finerenone, alongside the drugs that are commonly used in a pillared approach, did offer the promise of reduction in that UACR and showed safety in terms of potassium challenges. That being the case, I want to thank you very, very much for your attention this evening, and I certainly hope that you enjoyed it and learned quite a bit. At this point, I'll open up to question and answer session.
Thank you very much, Professor Morales. That was an amazing overview, taking us through the whole spectrum. And it opens definitely a lot of questions. And I think we're going to expect some updates in the guidelines as well. As you said, the heart failure studies, especially the heart failure with preserved and mildly reduced ejection fraction. So now, do you know if it already has the FDA approval for heart failure in the US? We're still waiting for it in Saudi for the HFpEF population.
Yeah, well, I mean, it is actually, yes, it is indicated. If we're looking at the first data point, which was very important, which was the Figaro study. The Figaro study did demonstrate not only an improved, or should I say, a reduction in the progression of chronic kidney disease related to diabetes, but also demonstrated reduction in major adverse cardiovascular events. So it does have that indication. Now, what's kind of interesting is that on the basis of safety relative to the steroidal-based agents, there is increasing utilization of finerenone, not just because of the safety, but because of the demonstrable effectiveness, even though the half-life is a little bit shorter. It's just the fact that it binds to that receptor a little bit better and has a more prolonged effect.
But I think for HFpEF specifically, for those with heart failure with preserved ejection fraction, I think we're still waiting for the FDA approval.
That's correct. And not just for HFpEF, but also heart failure with moderately reduced ejection fraction. Because when we're looking at that trial data, we're looking at patients with EFs of greater than 40%.
Yeah. So we call it mildly reduced
Yeah.
ejection fraction. So now, if you have a diabetic patient and you want to start treatment, he has chronic kidney disease or has some albuminuria, would you start SGLT2? And how would you start the treatment? Would you start SGLT2 and finerenone together? Would you wait for some time before when you start one after the other? Chronologically, how would you do it?
Yeah, so the practical answer is that you probably should be using these therapies concomitantly. You should be starting them together because what we've learned is using these medications conjointly will offer more benefit than just using one agent alone. So if you're planning on using one agent alone, we're falling into the realm of diabetes, which was basically treat the failure. Start one therapy, things get worse, add another therapy on. So I think that if we were to use both of these agents in combination, then the benefit is quite evident and sustainable. So we're basically derailing the progression that can happen or significantly reduce it relative to either agent alone. Of course, the challenge there is going to be availability and affordability. So oftentimes, I think that's a discussion that you have to have with your patient, whether or not the patient is willing to do both agents at the same time versus one or the other.
Excellent. I think you answered this question, but maybe someone wants to know the androgenic, any androgenic effects of finerenone compared to steroidal MRAs.
Yeah, and that's a fair question. The steroidal-based MRAs do have an effect on deoxycorticosterone and actually can reduce testosterone levels to some degree and what we call an anti-androgenic effect. But these are steroid-based preparations, and these are eplerenone and spironolactone. But the non-steroidal mineralocorticoid receptor antagonist, finerenone, because it's non-steroidally based, we're really not going to see that anti-androgenic effect as much. Not to say that you may never see it. Sometimes it could be seen because it's just pure chance. However, when I showed you the data compared to placebo, it was very similar in terms of the anti-androgenic effects and a breast hyperplasia that one can potentially see. So very, very, very low and significantly lower compared to spironolactone.
Now, the major drawback from up titrating the dose is probably hyperkalemia. How would you do in the presence of potassium binders? Would you just keep on going up and adding potassium binders if you need?
Well, I mean, that's a fair question, especially since potassium binders have become increasingly available and more affordable. So this is a risk-benefit ratio. If the benefit of being on finerenone outweighs the risk and the potassium can't be curtailed through dietary fashion, then the addition of a potassium binder seems to make sense. Again, because the benefit of being on the medication far, far outweighs the risk of not being on it. So I think that's a judgment call. And again, a discussion between you and the patient, but also, again, because we've never been so interconnected before, this is going to end up being a multi-specialty discussion because oftentimes these patients are quite complicated and they have nephrologists as well as cardiologists. So everybody needs to be on that same page. What's very nice is that when we're looking at potassium and hyperkalemia risk, it was significantly reduced by the presence of an SGLT2 inhibitor, which is another reason why we should be using the SGLT2 inhibitors in combination with.
So from your practice, do you see a difference in hyperkalemia and steroidal and non-steroidal versus non-steroidal MRAs?
Yeah, I mean, we still use a fair amount of steroidal-based MRAs and largely driven by affordability challenges. But compared to the mineralocorticoid receptor antagonists, I do see favorable changes in patients that may have been previously on a steroidal-based MRA and then get switched to the non-steroidal MRA. There is a notable reduction in that potassium. So yeah, I do see benefit. I totally do.
And from a practical point of view, how often do you monitor the potassium?
Well, I mean, some of these patients tend to be quite complicated, right? So, for the most part, that potassium is always assessed 4 weeks after initiation of finerenone. And if they're stable patients, I usually see them every 3 months or so just to assess. But the reality is that most of our patients are quite complicated and need help not just with blood pressure, their lipids, and monitoring their kidney functions, but also controlling their diabetes and their glycemic excursions. So sometimes I see them a little bit more frequently just because I'm measuring some of these other parameters. So if I'm going to be seeing them for their diabetes management and their thyroid and so forth, so I might as well just assess a potassium as well.
And part of it is definitely the kidney function and the presence of other medications that like RAS inhibitors, and so there's multiple factors that make us check, as you said, routinely these elements anyway.
Absolutely. And now we have a new class of drug that's coming out called the aldosterone synthase inhibitors, which also
Yes.
play into the RAS system as well. So we'll see how that plays out in the future.
Excellent. Dr. Morales, this was a very fruitful session and discussion, full of knowledge and excellent overview. I really thank you very much. I thank Bayer for sponsoring this session, and of course, this Saudi Heart Association and KR for conducting it. We wish you an excellent rest of your day, and I thank all the attendees for being here today as well. Thank you very much.
Thank you all, and I hope to see you soon.
Thank you. Have a good day.